Well, thank you for joining us today. This new series from MED-EL, the Spotlight series, is focused on professional education and hot topics related to treatment of hearing loss, be it conductive, mixed, or sensory neural. I'm joined today by Dr. Carol Liu from Texas Children's Hospital Microtia and Atresia Clinic. Dr. Liu attended medical school at Drexel University College of Medicine. She completed her residency in otolaryngology at University Hospital Case Medical Center and a fellowship in pediatric otolaryngology at Baylor College of Medicine. She is a board member of the American Academy of Otolaryngology Head and Neck Surgery and a member of the American Society of Pediatric Otolaryngology. Dr. Liu's clinical interests include microtia and atresia, chronic ear disease, sensorineural and conductive hearing loss management, sinus disease, and congenital head and neck masses. The Microtia and Atresia program at Texas Children's Hospital began in 2008. In addition to best-in-class repair and reconstruction services, they offer a multidisciplinary approach. Microtia Awareness Day was founded in 2016 by Melissa Tumblin and her organization, Ear Community. Ear Community is made up of children and adults with microtia, their families, teachers, advocates, and medical professionals from across the world who provide care for those with microtia and share experiences and resources. The first and most important step for parents and children born with microtia is to seek correct information regarding microtia as well as their treatment options. Programs such as the one at Texas Children's Microtia and Atresia Clinic are focused on providing information and solutions for each unique patient. Our primary goal of the discussion is to provide the hearing healthcare professionals and affiliated service providers watching this interview with strong foundational knowledge regarding microtia and atresia, as well as the resources available. Again, thank you for joining me, Dr. Liu. I appreciate your time.
Good morning, Kevin. It's very nice to be here.
Just kind of go ahead and kick things off quickly in looking at the different, aspects and perhaps some of the confusion with regard to the terminology we hear specific to microtia. It's microtia, atresia, anosia are all words that we see or hear related to this deformity. And I'm just curious with regard to the treatment and management of this population. What are the differences? And if you could shed some light on that for our audience, please.
Oh, that's a great question. I think even the terminology within the medical community and the medical literature, it depending on which definition you wanted to use at the time of publication. So as the name microtia suggested, micro meaning something small. So microtia in general encompass all ear abnormality when they're smaller than the normal size. However, anosia, it actually means there is no visible ear structures at all. So there's actually just a flat area in the region where the ear normally resides. So, but anosia does get encompassing into a microtia as the most severe form, as a grade 4 microtia. So those two terms, you will see them sometimes get combined together. Atresia is meaning for underdevelopment of the ear canal. However, atresia by its term means there is no ear canal whatsoever. It's just blind pouched or there is no formation whatsoever. However, sometimes people encompassing stenotic ear canal that's associated with a lesser severe form of microtia with atresia. So you also see atresia encompassing in some kids and adults where they actually just have a stenotic or smaller than normal ear canal.
Thank you for clarifying. It's great to know the different differences within the different terminologies and even the classification system for the series of microtia. Now, the population as a whole, I would assume that there is the potential for bilateral as well as unilateral microtia or atresia or anosia. Can you shed some light on the incidence of that, and then perhaps the philosophies with regard to treatment of this population?
let's talk about the unilateral first, because that is definitely more common than bilateral. Depending on which region you're focusing on, the demographic and the prevalence of microtia would change the incidence. So, for example, microtia tends to be more common among Hispanic and Asian population in comparison to Caucasian and African American. So depending on which country is doing the research study, we see the difference in terms of the incidence and prevalence. In terms of it's in general in the United States, we cited about 1 in 10,000 for unilateral microtia. Bilateral microtia is actually more rare. So we usually say it's about like 80 to 90% of unilateral versus 10 to 20% of bilateral that we're seeing. And then usually the management, at least from Texas Children's Hospital, our main focus is always hearing and speech. That is always our big philosophy when it comes to children with microtia is, are we providing adequate hearing augmentation, and are we providing enough speech therapy when it's necessary?
Thank you. I appreciate that insight. And I'm curious, does there tend to be a difference between male and female as far as the incidence and prevalence?
Yes, I forgot to mention that.
Sure.
And I always feel bad for the boys because it does happen about 3-to-1 ratio in boys versus in girls. So, and also interestingly, it actually occurs more often in the right side of the ear than the left side of the ear. So, so whenever I see children with the left side of microtia, it usually just tells me that it's interesting. It's not the more common side that I'm seeing. And I'm very big on checking for the hearing because even though most of them have conductive hearing loss, about 10% of the kids with microtia, unilateral or bilateral, they actually carry a potential sensorineural hearing loss component too. So 10% of the kids will end up with a mixed hearing loss.
Interesting. So this isn't just isolated to a conductive component. There's actually potential for a sensorineural as well.
Yes, that's correct.
Thank you. Oh, as far as treatment options, then there are non-surgical and surgical options, many different options available, some from MED-EL and other companies out there, Adhere, Bone Bridge, and several other names. Just curious, specific to a treatment plan, I'm assuming, given that this is present at birth, that intervention pretty much starts immediately with non-surgical options just to get the patient access to sound and hearing.
Yes, so that's correct. And even when I first started at Texas Children's Hospital in 2015, there is still some audiologists, interestingly, were still questioning the necessity of a hearing aid for children born with unilateral microtia or atresia. But I think over time with research, we have shown clearly children does benefit from a non-surgical hearing aid option that can start early. So our therapy, our approach to treatment option is a child with a microtia, they will most likely fail a newborn hearing screening because there's no way to test for hearing. So our goal is get them to us before 3 months of age to get an unsedated hearing auditory brainstem response test, ABR, in our clinic. And while we once we identify the type of hearing loss they have, then we ask for an insurance company or Medicaid to get them fitted with a hearing aid with a goal to fit them by 6th month of age. And the reason a lot of times we say 6 months is mainly for the babies at that point have more head controls. So their hearing aid, whichever type they choose to wear, is not rubbing against the blanket that they're rolling on. They're more likely to be sitting and receiving the sound from the environment.
To your point, the unilateral versus bilateral and just the appropriate placement of whichever solution they're wearing ultimately increases the quality of life and the quality of the outcomes that they receive from the intervention, be it a hearing aid or non-surgical bone conduction solution, just making sure it's appropriately placed each time they actually put it on.
Yes. And for the
Now,
children, so for the children with bilateral, we actually even try to push the timeline even tighter. We even try to get them tested and fitted by 3 months of age when we can. And again, sometimes I limited on family resources to be able to come to the hospital for multiple testing.
very interesting. And I guess that with regard to the different approvals and indications and clearances available, that somewhat dictates what options are available specific to the age of the child. Say, add here is an option from MED-EL non-surgical that's available as soon as the child is born, actually wearing a headband or an adhesive option. And then some of the surgical options may be dictated by 12 years and above or other criteria from the FDA. Specific to, you mentioned 3 and 6 months is kind of benchmarks for trying to get different assessments and fitting done. Are there other protocols or benchmarks, goals that you're shooting for with regard to potentially surgical intervention or future reconstructions and things like that?
Yeah, so one of the things to consider for children with atresia and microtia is some of them would have issue with congenital cholesteatoma. It's not high, but it is a potential. So most of the children would get this imaging study, and most of the institutions that handle patients with microtia, the kind of general consensus is around 5 years of age, a CT temporal bone without contrast will be obtained. Part of it is to rule out any potential congenital cholesteatoma in the deep temporal area. And secondly, it actually helps us to determine whether or not the children can be an atresioplasty candidate, or in the case where they're not a favorable atresioplasty candidate, what's their surgical candidacy look like for bone conduction hearing implants.
Now, taking a step back too, we discussed the multidisciplinary nature of your team and the different, you've mentioned the audiologist and speech language pathologists, and I'm assuming educators are also involved, perhaps social workers. Could you shed some light on the makeup of your team and the disciplines that are involved in treating this unique disorder?
Yes, for sure. I always say it takes a village to take care of a child with microtia. And I'm very fortunate at Texas Children's Hospital that I have a great team. We do have a microtia coordinator, which takes on the role usually for coordinating all the hearing aid appointment, hearing aid fitting, any potential school or insurance company requests for upgrade or coordination of their hearing aid equipment in school. Speech therapy is actually very important at early on age. A lot of the parents will ask me, like, why do I need speech therapy when the baby is only cooing? What we really recommend is actually auditory verbal therapy, AVT. So what they are doing is helping the family, in addition to the once a week therapy or twice a week therapy, to stimulate their children into receiving the auditory input from the environment and producing sounds. So we actually recommend children, as once they identify the hearing loss, to be followed by auditory verbal therapist. And in addition, we have a strong social worker department in our hospital, which does help us significantly with any financial aid or Social Security need, Social Security financial aid that the parents might need.
Amazing. It's wonderful to hear that it's such a dynamic team working to make sure that these families and these children get what they need with regard to access to hearing. And then keeping in mind too, I had mentioned ear community as well, the ability for these families to connect with other families who are living this and going through this process, and just getting a sense of what that path may look like and what resources are available to them to help either on the financial side or just a peer-to-peer discussion, and getting a sense from others what it's like to go through the process, and perhaps wear hearing aids or go through the surgical reconstruction or perhaps a bone conduction implant. This community is just simply amazing with regard to all the different access that these families and these children have. Texas Children's and the Microtia and Atresia Clinic there does a phenomenal job in making sure these children have access to this as soon as possible and throughout their lifetime. And I do want to say thank you again for your time today and sharing your insights and the resources that you have available through the program at Texas Children's. For additional information with regard to any of the programs that we've discussed today, Adhere, Bone Bridge, Texas Children's, Microtia and Atresia Clinic, your community, please follow up on the links that will be available at the end of this discussion. Thank you very much. Have a wonderful afternoon.